A very good morning to everyone. My name is Dr. Siddharth, and I'll be presenting an interesting case of Axenfeld-Rieger syndrome with dome-shaped maculopathy and detachment of Schwalbes line. Axenfeld-Rieger syndrome affects 1 in 200,000 live births, affecting both the genders equally, and it is typically identified in infancy and childhood. Inherited by autosomal dominant fashion, however, sporadic cases also may arise. The common mutations that are associated with this conditions are PITX2, FOXC1, and a gene on chromosome 30. Our case involves a 28-year-old male who was referred to us with blurred and distorted vision in his right eye for the past 3 months, along with a noticeable reduction in pupil size compared to his older photographs. He was previously diagnosed with posterior embryotoxon in 2017, and he was on routine follow-up elsewhere. The patient was referred to us to evaluate the possibility of right eye pupilloplasty because the treating physician concluded that the symptoms were because of the pupillary defect. His right eye, the best corrected visual acuity was 6.9, IOP, central corneal thickness and axial lengths were normal. The cornea was a little smaller in size, 10 into 10 mm. There was 360-degree posterior embryotoxon with a fairly clear central cornea. The iris had posterior peripheral anterior synechiae and multiple hypoplastic areas. The pupil was eccentric 1 mm, slit-like and briskly reactive to light. In the right eye, the vision was normal, IOP, CCT and axial lengths were normal, the cornea was smaller. There was posterior embryotoxon with peripheral anterior synechiae with areas of hypoplastic iris and a partially detached Schwalbes ring which appeared irregular white thread-like in the anterior chamber attached to the iris. On gonioscopy and ASOCT, it was suggestive of underdeveloped angle structures with typical Axenfeld anomaly. The fundus in the right eye showed a little hyperemic disc with evidence of subretinal fluid and some pigmentary changes at the macula. The left eye fundus was normal. On OCT macula, in the right eye, there was some subfoveal serous detachment along with mild convexity of the macula on both horizontal and vertical raster scans. And left eye OCT was normal. So the patient was diagnosed with bilateral Axenfeld-Rieger anomaly with dome-shaped maculopathy in the right eye with a differential diagnosis of CSCR. Since there was no evidence of glaucoma at presentation, he was advised routine follow-up. However, for subretinal fluid, he was advised repeat OCT after 1 month, and it was concluded that metamorphopsia was because of the macular pathology rather than the pupillary defect, and pupilloplasty was deferred. Another case which we encountered last year was a 6-year-old child with similar presentation of detached Schwalbes line with hypoplastic iris and ectropia on UVA. However, unlike our previous case, in this case, the child had dental anomalies as well, along with glaucomatous damage and needed surgery in both the eyes. On literature review, there have been few cases of detached Schwalbes line, but the incidence of glaucoma is fairly variable, with one case reporting no glaucoma, another early glaucoma, and some cases reporting advanced glaucoma. Coming to discussion, Axenfeld-Rieger syndrome includes overlapping phenotypes of 3 known gene defects, and the single most important phenotype is 50% or greater risk of developing glaucoma. The previous case reports have concluded that because of the common origin of the iris stroma and the Schwalbes line, because of incomplete cleavage, there can be detachment of the Schwalbes line in cases of Axenfeld-Rieger. And although there have the maculopathy have not been reported in Axenfeld-Rieger syndromes, there has been a case report of foveal hypoplasia in a family of 3 generations of a same family. So the take-home message from my presentation is Axenfeld-Rieger anomaly can present with a myriad of anterior segment findings, and sometimes it can present with unilateral or bilateral detached Schwalbes ring. And glaucoma may not necessarily correlate with the extent of anterior segment dysgenesis. However, it does correlate with the iris insertion. If it is anterior, the incidence of glaucoma is more. And the third and the most important point is the detailed posterior segment evaluation. It might sound very benign, but when the child is very young, or where there is a gross pupillary defect, or if the anterior segment findings are very overwhelming, and as we see in Axenfeld-Rieger syndrome, the finer details of the macula and the peripheral retina might be missed. Thank you.
So this is the only case of Axenfeld-Rieger with detached Schwalbes ring with maculopathy, dome-shaped maculopathy.
Yes,
Because
sir.
in literature what you
Yes.
said was the previous other case which had was foveal
Foveal
hypoplasia,
hypoplasia, sir, but no
not
maculopathia.
dome-shaped maculopathia. So what do you intend to do for this maculopathia?
Because there was no, because glaucoma, he had no glaucoma, we had asked for glaucoma review every year.
No,
And
glaucoma is ruled out,
yeah,
but
yeah.
he had
For,
metamorphopsia.
yes, sir.
So-
For that, for now, because the subfoveal fluid was minimal, they had asked for repeat OCT after a month to see if it is progressing or not, and depending on that, they will either
If
plan.
it is stationary, what do you do?
If the patient is symptomatic, we'll.
It is
Yeah, yeah.
metamorphopsia.
Yes, sir.
Your title says metamorphopsia.
Sir, we'll plan for intravitreal injection.
How old is the patient?
28, sir.
For CSR, it's like a subretinal fluid.
Yes, sir.
Subretinal
Yes,
fluid,
ma'am.
how will intravitreal injection help? What is the role of intravitreal injections in CSR?
It can reduce the subretinal fluid,
Does
ma'am.
it?
I'm not sure, ma'am.